Welcome to the Deep Dive. We're the show that takes complex source material and really breaks it down, giving you those vital insights, basically a shortcut to being genuinely well-informed.
That's the goal.
Today, we are diving really deep into thyrotoxicosis and hyperthyroidism. We've gone through Williams' textbook of endocrinology pretty meticulously, distilling, all the key concepts, the nuances. Everything. The aim here is to give you a truly comprehensive understanding, the kind that seasoned professionals in this field have.
Right, equipping you with that mastery.
Exactly. From the basic definitions all the way to, well, critical emergencies and the very latest treatments. So let's unpack this. It's quite a journey through the body's systems, isn't it? All reacting to too much thyroid hormone.
It really is.
And here's something that honestly surprised me and really shows the range. Did you know that in older patients, the symptoms can be so subtle they call it apathetic thyrotoxicosis? It can sometimes look like heart failure or even dementia.
It's true. And yet,
in younger people, it can be the total opposite, extreme restlessness, almost psychosis sometimes.
And that's what's so fascinating, how this one imbalance, just too much thyroid hormone, can ripple out and affect nearly every single organ. It creates this symphony, if you will, of really diverse clinical signs.
A symphony, or maybe sometimes a cacophony.
Depending on the severity, yes, maybe cacophony is better. But it really highlights why a thorough grasp is so important.
Absolutely. So let's start right at the foundation, the terms themselves. Thyrotoxicosis and hyperthyroidism. People often use them interchangeably, right?
Generally, yes.
Yeah.
In practice, they both refer to the effects, whether they're obvious or quite subtle, of having too much thyroid hormone floating around.
And it's not exactly rare. What are the numbers again?
It affects about 1 to 2% of women and maybe 0.1 to 0.2% of men. So quite prevalent, especially in women.
Okay. So how does this excess hormone actually happen? What are the main ways?
Well, you can think of it in sort of 3 main buckets. First, the thyroid gland itself might just be stimulated too much, working overtime. That's the classic scenario in Graves' disease.
Okay, overproduction.
Exactly. Second, the thyroid might be damaged, maybe inflamed, and it just starts leaking out the hormone it already had stored. That's what happens in thyroiditis. It's not making more, it's just releasing it passively.
Passive release, right.
On the third is when the hormone comes from somewhere outside the thyroid gland altogether. Most commonly, this is someone taking too much thyroid medication, either accidentally or intentionally.
Got it. Overproduction, leakage, or external sources. So how do we first pick up on this biochemically? What's the initial clue in the blood work?
The very first and often most sensitive indicator is a suppressed TSH level. That's thyroid-stimulating hormone.
Suppressed meaning low?
Very low, typically less than 0.1 milliunits per liter. This often happens even before someone feels any obvious symptoms.
Wow.
Then to confirm, we look for elevated levels of the actual thyroid hormones in the blood, specifically the free, unbound forms of T4 and sometimes T3.
So low TSH, high T4 or T3. That's the pattern.
That's the basic biochemical signature, yes.
All right, so once we have that biochemical hint, how do we drill down and figure out why? Which of those 3 buckets, overproduction, leak, or external, are we dealing with?
This is where the diagnostic toolkit comes in. And one of the most critical tools is the radioactive iodine uptake test, the RAIU.
Radioactive iodine. How does that work?
Well, the thyroid gland naturally takes up iodine to make hormones. So we give a tiny, safe amount of radioactive iodine and see how much the thyroid absorbs.
Oh, okay.
If the thyroid is actively overproducing hormone, like in Graves' disease, it'll be hungry for iodine and the uptake will be high.
Makes sense.
But if the problem is thyroiditis, that leaky gland scenario, the damaged cells aren't actively taking up iodine, so the uptake will be very low, often less than 5%. It's a really key differentiator.
High uptake means making too much. Low uptake means leaking or maybe an external source. That's clear. What about antibodies, especially for Graves'?
Exactly. For Graves' disease, which is autoimmune, we look for TSH receptor antibodies, or TSH-RABs. Finding these antibodies, especially the stimulating kind, pretty much confirms Graves' disease. They're the culprits mimicking TSH and telling the thyroid to go into overdrive.
And you mentioned thyroglobulin, THG. Where does that fit?
Thyroglobulin is a protein made only by thyroid cells. So if someone has hyperthyroidism because they're taking external thyroid hormone pills, their own thyroid isn't working much, and their TG level will be very low, almost undetectable.
Ah, so low T points away from the thyroid itself being the source.
Precisely. Whereas in thyroiditis, when the gland is leaking, TG levels will actually be high because it's spilling out along with the stored hormone.
Okay, that's another useful clue. And lastly, visualizing the gland. Ultrasound.
Ultrasound is very helpful. It shows us the size of the gland, whether it's diffusely enlarged like in Graves, or if there are specific nodules like in toxic multinodular goitre. It can also show blood flow. Graves typically has very high blood flow, while thyroiditis often has low flow.
And scintigraphy, is that similar to the uptake test?
Scintigraphy uses a radioactive tracer too, but it gives us a picture, a map, of where the activity is in the thyroid. It's particularly useful if there are nodules, to see if they are the hot spots producing excess hormone, or if the whole gland is hot like in Graves.
Okay, this diagnostic process makes a lot more sense now. Let's shift gears to what the patient actually experiences. How does this excess thyroid hormone manifest in the body? You said it's like metabolic overdrive, but it varies.
It really does. And this raises the fascinating point. Why do patients sometimes miss these pretty profound changes? They might just chalk it up to stress or aging or, just life.
Right.
And age is a huge factor in how it presents. But one diagnostic clue is actually the duration of symptoms.
How long it's been going on?
Exactly. With true hyperthyroidism, like Graves or a toxic nodule, the symptoms tend to creep up over months. Maybe fatigue, maybe gradual weight loss despite eating more, maybe feeling hot. It's insidious.
Sneaks up on you.
Whereas with thyroiditis, that leakage scenario, it's usually much more abrupt. People often feel unwell and seek help within maybe a month because the hormone dump happens relatively quickly.
That's a really useful distinction, months versus weeks.
It's a helpful guidepost, yeah?
And let's circle back to the elderly and this apathetic or masked thyrotoxicosis. It sounds quite dangerous if it's being missed.
It absolutely can be. In older patients, you might not see the classic restlessness or heat intolerance at all. Instead, the presenting problem could be new-onset atrial fibrillation or worsening heart failure or just significant unexplained weight loss without that increased appetite you see in younger folks. It can even present as confusion or depression, mimicking dementia.
Wow. So clinicians really need to keep it on their radar for older adults with those symptoms.
Definitely. It's a crucial consideration.
Let's dig into the systems, starting with the cardiovascular system. You mentioned heart failure and atrial fibrillation. What else happens?
Well, the heart is working harder. There's decreased resistance in the peripheral blood vessels because the body is trying to dissipate heat. This makes the heart pump more blood volume with each beat that's increased cardiac output.
So faster and harder.
Faster and harder, exactly. Tachycardia, a fast heart rate, is almost always present. It's driven by both direct effects of thyroid hormone on the heart muscle and increased sympathetic nervous system activity.
And you feel that as palpitations.
Often, yes. Patients might describe a racing or pounding heart. You also typically see a widened pulse pressure. It's the difference between the top systolic and bottom diastolic blood pressure numbers. The systolic goes up because the heart's pumping forcefully, and the diastolic might stay the same or even drop a bit due to that relaxed vascular resistance.
And atrial fibrillation, AFib, you said is common?
Very common, especially in those over 60. Maybe 2 to 20% of thyrotoxic patients develop it. And it's important to know that trying to electrically convert someone out of AFib while they're still thyrotoxic often doesn't work well. Many patients, maybe 60%, will actually convert back to a normal rhythm on their own once their thyroid levels are treated.
Good to know. And heart failure.
Usually happens in people who already have some underlying heart condition. The extra strain from the thyrotoxicosis just pushes them over the edge into failure.
Okay, moving to the metabolic system. What's happening with appetite, weight, protein, fats?
It's like the body's furnace is turned way up. Metabolism increases, generating more heat. This usually leads to increased appetite.
But people often lose weight, right?
Paradoxically, yes. Despite eating more, the calorie burning is so ramped up that they often end up in a chronic calorie deficit leading to weight loss. In severe cases, the body starts breaking down protein, especially muscle, which can lead to muscle wasting and even slightly lower protein levels in the blood.
And lipids, cholesterol.
Fat breakdown lipolysis is increased. So you see higher levels of free fatty acids in the blood, but often lower levels of total cholesterol and triglycerides. It can also worsen pre-existing diabetes.
Okay. What about the nervous system and muscles? This sounds like where some dramatic symptoms can appear.
Oh, definitely. Nervousness, anxiety, emotional lability, quick mood swings are very common. There's often a kind of restlessness, hyperkinesia, where the person seems unable to sit still, maybe fidgety, quick, jerky movements.
Almost levitating, as the textbook sometimes describes it.
Exactly, that kind of feeling. Insomnia is common too, yet paradoxically, so is fatigue. In rare, very severe cases, you can even see significant psychiatric disturbances, mania, depression, even psychosis.
And in children?
It might manifest as poor school performance, difficulty concentrating, kind of like ADHD symptoms. And then there's the tremor.
The fine tremor, right.
Yes, a fine tremor, especially noticeable in the outstretched hands or sometimes the tongue or eyelids.
And muscle weakness. You mentioned muscle wasting.
Yes, proximal muscle weakness is common. That means weakness in the muscles closer to the center of the body, shoulders, hips. Patients might complain of difficulty climbing stairs, getting up from a chair, or combing their hair. It's sometimes called thyrotoxic myopathy.
Are there links to other muscle or nerve conditions?
There are. There's an association with myasthenia gravis, another autoimmune disease affecting muscle control. A small percentage of MG patients have Graves, and vice versa.
Interesting.
And another important one, especially in Asian and Latino men, is hypokalemic periodic paralysis. They can have sudden episodes of severe muscle weakness, triggered by things like high-carb meals, due to shifts in potassium levels related to the thyrotoxicosis.
Okay. Now what about visible signs? Eyes, skin, hair.
For the eyes, even outside of the specific condition Graves' orbitopathy, almost any type of thyrotoxicosis can cause signs related to increased adrenaline-like activity. Eyelid retraction is common. The upper eyelid pulls up slightly, showing a bit of white above the iris. Kind of staring appearance, yes. And also lid lag, where the upper eyelid lags behind the eyeball when the person looks down. These are different from the inflammation and bulging seen in Graves' orbitopathy itself.
Got it. And skin and hair.
Skin is typically warm, moist, maybe a bit flushed or rosy. Palms might be red, palmar, erythema. Hair often becomes fine, brittle, and there can be increased hair loss, diffuse thinning.
And plumber nails, what's that?
That's onycholysis, where the nail starts separating from the nail bed underneath, usually starting at the tip. It often affects the fourth and fifth fingers, most noticeably. Vitiligo, those patches of depigmented skin, is also seen more often in people with autoimmune thyroid disease.
Let's quickly touch on some other systems. Respiratory.
People might feel short of breath, partly due to increased oxygen demand and potentially weakened respiratory muscles. It can definitely worsen underlying lung conditions like asthma or COPD.
Digestive system.
Increased gut motility is common, leading to more frequent bowel movements, sometimes diarrhea. Malabsorption can occur in severe cases, and there's a known association with celiac disease and pernicious anemia, other autoimmune issues.
Liver.
Mild liver enzyme elevations can happen. In severe thyrotoxicosis or thyroid storm, more significant liver dysfunction, even jaundice, can occur.
And bones. This sounds important, especially for long-term health.
It is. Excess thyroid hormone speeds up bone turnover, but the breakdown process, resorption by osteoclasts, outpaces the building process. This leads to a net loss of bone mineral density.
So increased risk of osteoporosis and fractures.
Definitely, especially in postmenopausal women. It's a significant concern. You also often see increased calcium and phosphorus levels in the urine, and mild hypercalcemia, high blood calcium, is fairly common. This bone effect is also why we worry about long-term TSH suppression therapy in thyroid cancer patients, particularly women after menopause.
Right, that makes sense. Kidneys, blood.
Kidneys usually show increased blood flow and filtration rate, maybe leading to mild polyuria, urinating a bit more. In the blood, red blood cell mass might increase, but white blood cell counts, particularly neutrophils, are often low. Lymphocytes might be relatively increased. In Graves' disease, the spleen and thymus can sometimes be enlarged.
Any impact on blood clotting?
Interestingly, levels of factor VIII, the clotting factor, are often increased. However, patients tend to have an enhanced sensitivity to warfarin, the blood thinner. So if someone with thyrotoxicosis needs warfarin, they might require lower doses than usual.
That's a critical point for safety. Lastly, other endocrine interactions. Cortisol. Reproduction.
Cortisol metabolism is sped up, but the adrenal glands usually compensate by producing more, so blood levels stay normal. For reproduction, thyrotoxicosis can delay puberty if it occurs early. In adults, women often experience menstrual irregularities, reduced fertility, and a higher risk of miscarriage. Men can sometimes develop gynecomastia, breast enlargement, or erectile dysfunction, partly due to changes in how sex hormones are metabolized.
Okay, that paints a really comprehensive picture of how widespread the effects are. So, knowing all this, how do we connect these symptoms back to the specific underlying cause? Let's dive into the main culprits, starting with the most common one, Graves' disease.
Absolutely. And connecting back to the bigger picture, figuring out the precise etiology, the exact cause, isn't just an academic exercise. It fundamentally dictates the treatment strategy and affects the long-term prognosis.
Right.
So Graves' disease, at its core, it's a multi-system autoimmune disorder. The immune system mistakenly creates antibodies, those TSH receptor antibodies we talked about, that act like agonists, meaning they stimulate the TSH receptor on the thyroid glands.
So they're basically pressing the on button constantly.
That's a perfect analogy, constantly telling the thyroid to grow and make more hormone.
How did we figure this out? It sounds complex.
It evolved over time. Early descriptions noted the classic triad of palpitations, goitre, enlarged thyroid, and exophthalmos, bulging eyes.
Yeah.
But the real breakthrough came in the late 1950s with the discovery of a substance in the blood of Graves' patients called LATS, long-acting thyroid stimulator.
LATS.
Yeah, it was later identified as immunoglobulin G, an antibody that was stimulating the thyroid. That really cemented the autoimmune nature, and realizing these antibodies could cross the placenta explained why babies born to mothers with Graves could have temporary hyperthyroidism. We also learned that TSH receptors aren't just on the thyroid, they're on cells in the eye sockets, orbital fibroblasts, and skin, dermal fibroblasts, which explains the eye and skin manifestations sometimes seen in Graves.
And what does the thyroid tissue itself look like in Graves?
Microscopically, the gland is usually diffusely enlarged. The thyroid follicles, the little sacs that make hormone, are hyperplastic. The cells are enlarged and crowded. And you typically see infiltration by lymphocytes, those immune cells, scattered throughout the tissue. It looks busy, overactive.
Let's go deeper into the immune side, the immunopathogenesis. How does the immune system go wrong here?
It's fundamentally a breakdown of self-tolerance. The body fails to recognize the TSH receptor as self. This involves both genetic predisposition and environmental triggers.
How does the breakdown happen?
Well, normally the thymus gland does a pretty good job of eliminating T cells that react strongly against self-antigens during their development, but some might escape. There are also peripheral mechanisms involving regulatory T cells, TREGs, that are supposed to keep any escaped self-reactive T cells in check.
And in Graves?
In Graves, there seems to be a problem with both central tolerance in the thymus and peripheral tolerance. Maybe more self-reactive T cells escape, or the TREG function is impaired. There's often an imbalance with fewer TREGs and more pro-inflammatory T cells, like Th17 cells.
And the target is the TSH receptor.
Exactly. The TSH receptor itself, particularly a shed part of it called the alpha subunit, seems to be the primary autoantigen that the immune system mistakenly attacks. When those stimulating TSH receptor antibodies, TSH-RABs or TRABs, bind, they activate the signaling pathways inside the thyroid cell, leading to growth and hormone production. There can also be blocking antibodies or neutral antibodies, but the stimulating ones cause the hyperthyroidism.
Okay, so what makes one person susceptible versus another? You mentioned genetics and environment.
Right, it's a complex interplay. First, there are existential factors. It's much more common in women, about 4 times more. The reasons aren't fully clear, but hypotheses involve things like X chromosome inactivation patterns or maybe effects from pregnancy, like fetal cells persisting in the mother's circulation.
And the genetic component.
It's significant. Twin studies suggest genetics account for a large part of the susceptibility, maybe around 79%. We've identified several genes that increase risk. Some are directly related to the thyroid, like the TSHR gene itself or the thyroglobulin gene. Others are key immune regulatory genes, HLA genes, CTLA4, PTPN22, CD40, CD25. These affect how immune cells are activated and controlled.
So variations in these genes make the immune system more likely to attack the thyroid.
That's the idea. But importantly, all the genes identified so far only explain maybe 10% of the total heritability. So there are likely many more genetic factors we haven't found yet.
And then the environmental triggers kick in on top of that genetic susceptibility.
Precisely. These are crucial. Iodine intake is one. Moving from an iodine-deficient area to an iodine-sufficient one can temporarily increase Graves' incidence. This is sometimes called the Jod-Basedow effect in susceptible individuals.
What about lifestyle?
Smoking is a major one, a very strong risk factor, more than tripling the odds. The good news is the risks seem to disappear a few years after quitting.
That's huge.
And interestingly, moderate alcohol consumption seems to be protective, associated with a considerable reduction in risk.
Really? That's counterintuitive.
It is, but the association seems consistent in studies. Stress has always been implicated, right back to the earliest descriptions, but proving it prospectively is difficult.
Infections.
There are theories about molecular mimicry, where a bug might look similar to a thyroid protein tricking the immune system. Yersinia enterocolytica has been mentioned. But strong population evidence is lacking for most infections. However, hepatitis C virus infection is clearly linked to a higher risk of autoimmune thyroid disease, including Graves.
And medications.
Yes. Interferon alpha, used for hep C and other conditions, was a known trigger. And now, the newer immune checkpoint inhibitors used in cancer therapy drugs like ipilimumab, nivolumab, pembrolizumab can definitely cause thyroid problems, including Graves' or destructive thyroiditis, by unleashing the immune system.
Immune reconstitution, too.
Yes, after treatments that deplete lymphocytes like alemtuzumab for MS, as the immune system recovers, it can sometimes trigger autoimmunity, including Graves'.
Once someone develops Graves', what's the typical course? Does it remit?
It's variable and hard to know the true natural history since most people get treated. But the thinking is there might be three main patterns: a prolonged, continuous course, a relapsing remitting course, or maybe a single episode followed by permanent remission, perhaps in around 40% of cases.
How do you know if remission is likely?
Indicators during treatment include the goitre shrinking, TSH receptor antibody levels falling, and TSH levels normalizing. Factors suggesting a higher risk of relapse after stopping treatment include being a smoker, having large goitre, active eye disease, or very high thyroid hormone or antibody levels at diagnosis. There are even scoring systems, like the GRADE score, that try to predict relapse risk.
And long-term outcomes.
There is evidence of increased all-cause mortality in Graves' patients, particularly from cardiovascular and lung diseases. This risk seems linked to the cumulative time spent with suppressed TSH levels, emphasizing the importance of achieving stable thyroid function.
Okay, let's talk treatment for Graves' hyperthyroidism. What are the mainstays?
The three main modalities are antithyroid drugs, ATDs, thyroidectomy surgery, and radioactive iodine, RAI. It's important to remember none of these actually fix the underlying autoimmune problem. They manage the overactive thyroid itself.
Let's break down ATDs first. Methimazole, carbimazole, PTU. How do they work?
They primarily work by inhibiting enzymes within the thyroid gland that are essential for making thyroid hormones, specifically thyroid peroxidase. PTU has an extra action. It also blocks the conversion of T4, the main storage hormone, into T3, the more active form, in peripheral tissues. That's why PTU is sometimes preferred for very severe cases or thyroid storm where you want a rapid effect. Methimazole, MMI, has a longer duration of action, so it can usually be given once a day. PTU needs to be taken 2 or 3 times a day. They also seem to have some immunosuppressive effects, helping to lower those TSH receptor antibody levels over time.
What are the really critical side effects? You mentioned agranulocytosis earlier.
Agranulocytosis is the most feared, though rare, maybe 0.2 to 0.5% of patients. It's a sudden, drastic drop in neutrophils, a type of white blood cell crucial for fighting infection. It usually happens within the first few months.
And it comes on suddenly.
Very suddenly.
Mm-hmm.
That's why routine blood count monitoring isn't really effective at catching it. The absolute critical piece of patient education is, if you develop a fever or a sore throat while on these drugs, stop the medication immediately and get a blood count checked right away. Don't wait. If it occurs, that drug class is generally avoided in the future.
That's vital information. What about the liver issues with PTU?
Yes. PTU carries a risk of severe, potentially fatal liver failure, sometimes requiring a transplant. This risk, although low, led the FDA and other bodies to issue advisories. PTU is generally no longer considered first-line therapy except in specific situations.
Which situations?
The main exceptions are the first trimester of pregnancy, thyroid storm, or if a patient has had a significant reaction to methimazole and surgery or RAI aren't options. MMI can also cause liver issues, but typically milder cholestatic injury, not usually severe failure. Other rare side effects include vasculitis, inflammation of blood vessels, and pancreatitis.
So MMI is generally the go-to ATD now for most people.
For most non-pregnant adults and children starting therapy, yes, MMI is usually preferred due to the better safety profile regarding severe liver injury.
How is treatment managed? Titration? Block and replace?
You can do either. Titration involves starting with a moderate dose and adjusting it down based on thyroid function tests to find the lowest dose that keeps the patient euthyroid, normal thyroid levels. Block and replace involves using a higher, fixed dose of ATD to fully block thyroid production and then adding back thyroid hormone, levothyroxine, to keep levels normal. Titration is generally preferred now.
How long do people typically stay on ATDs?
The traditional course is about 12 to 18 months, after which you assess for remission. Remission rates are maybe 50–60% on average. However, there's growing evidence supporting the safety and potential benefit of longer-term, low-dose ATD therapy, sometimes for many years, which might lead to higher remission rates or just be a good long-term management strategy for some. Checking TSH receptor antibody levels before stopping can help predict remission likelihood.
Okay. Option 2, thyroidectomy, surgery.
Surgery offers the most rapid and definitive cure, especially near total or total thyroidectomy, where the risk of recurrence is almost zero.
But it requires a skilled surgeon.
Absolutely crucial. High-volume thyroid surgeons have significantly lower rates of the main complications. Permanent hypoparathyroidism, damage to the parathyroid glands controlling calcium, and recurrent laryngeal nerve injury affecting the voice. Bleeding is also a risk.
How do you prepare someone for surgery?
They need to be made euthyroid first, usually with ATDs and maybe beta blockers. Often, potassium iodide drops are given for 7-10 days right before surgery. This helps decrease the blood flow to the very vascular Graves gland, making the operation safer and easier.
And post-op, you mentioned hungry bones.
Yes. After removing the overactive thyroid, the bones, which were losing calcium, can suddenly start taking it back up rapidly. This can cause a temporary but sometimes severe drop in blood calcium, hypocalcemia, requiring calcium and vitamin D supplementation.
All right, option 3, radioactive iodine, RAI.
RAI has been used for decades. It delivers radiation specifically to the overactive thyroid cells, causing them to die off over weeks to months.
What's the goal? Euthyroidism or hypothyroidism?
The current recommendation from major societies like the American Thyroid Association is actually to aim for hypothyroidism with RAI. Give a dose sufficient to ablate or destroy the thyroid function.
Why aim for hypothyroidism?
Because studies suggest long-term outcomes, especially cardiovascular outcomes, are better when patients become hypothyroid and are then managed with stable levothyroxine replacement, compared to trying to achieve euthyroidism with RAI, which can be difficult and sometimes lead to fluctuating levels or recurrence.
What about the cancer risk concern?
It's a common question. Decades of follow-up studies have shown that the overall risk of developing cancer after RAI for hyperthyroidism is extremely low if present at all in adults. It's generally considered very safe. Age limits for use have even come down, although there's still maybe a slightly higher theoretical risk in very young children, where ATDs are often preferred first.
Contraindications.
Absolutely contraindicated in pregnancy and breastfeeding. A negative pregnancy test is required beforehand.
And the big complication risk with RAI, the eyes.
Yes. Graves' orbitopathy, GGO.
Right.
RAI treatment can cause new onset or worsening of GO in about 15% of patients. This is thought to be due to a temporary surge in TSH receptor antibodies after the thyroid cells are damaged.
But this can be prevented?
Critically, yes. For patients with existing GGO or risk factors like smoking, giving a concurrent course of low-dose oral steroids, like prednisone, 0.3, 0.5 milligauss sheet a day, tapered over 3 months, starting shortly after RAI can effectively prevent this worsening in most cases.
That's essential to know. Any other RAI issues?
Sometimes transient radiation thyroiditis can occur a week or so after treatment, causing temporary neck pain or brief worsening of hyperthyroid symptoms. Beta blockers can help manage this. Preparation usually involves stopping ATDs for a few days beforehand to allow good uptake and confirming no pregnancy. Radiation safety precautions are also discussed.
So with these 3 distinct options, ATDs, surgery, RAI, how do you choose?
It really comes down to shared decision-making. The physician presents the pros and cons of each, considering the patient's specific clinical situation, age, goiter size, eye disease, severity, pregnancy plans, and very importantly, the patient's preferences and values.
Are there general guidelines or leanings?
ATDs are often favored initially, especially if remission seems likely or if there's significant active eye disease. Surgery might be preferred for large goiters causing compression, suspected cancer, if rapid control is needed, like planning pregnancy soon, or if ATDs RAI are contraindicated or disliked. RAI is a good option for relapses after ATDs, older patients, or those who prefer to avoid surgery or long-term medication.
And you mentioned a shift in the U.S.
Yes, historically, RAI was often the first choice in the U.S., but practice patterns have shifted significantly. Now, ATDs are the most common initial treatment to the U.S., more aligned with European practice.
Are there other drugs used sometimes?
Beta blockers, like propranolol, are very important for symptom control, heart rate tremor, while waiting for definitive therapy to work. Propranolol also slightly inhibits T4 to T3 conversion. Iodine, Lugol solution, or SSKI, can be used short-term for rapid decrease in hormone release, like before surgery or in storm, but not long-term. Lithium can sometimes be used to inhibit hormone release. Cholestyramine can help clear hormone from the gut, and research continues on newer approaches like TSH receptor antagonists, though they aren't standard yet.
Okay, let's transition to Graves' orbitopathy, or GRO. You've mentioned it several times. It's often a major concern for patients, almost like a separate disease.
It really is. And it's a prime example of how that autoimmune attack spills over from the thyroid to another site, the orbit, the eye socket, because those orbital fibroblasts also express the TSH receptor. It's one of the most challenging aspects of Graves to manage.
What are the hallmark symptoms?
It varies widely. Early on, it might just be eyelid swelling, redness, a gritty or sandy feeling, excessive tearing, sensitivity to light. Then you can get the eyelid retraction, the proptosis or exophthalmos, bulging eyes, double vision, diplopia due to muscle involvement, and in severe cases, pain behind the eyes.
And the most serious complication?
Dysthyroid optic neuropathy, or DON. This is where the swollen muscles at the back of the orbit compress the optic nerve, threatening vision. It's an emergency. DON tends to appear later in life and be more severe in men and older individuals compared to younger women.
You mentioned the pathology involves swelling of muscles and fat behind the eye.
Exactly. Those orbital fibroblasts get activated by the TSH receptor antibodies, and they start producing large amounts of glycosaminoglycans, or GAGs. These are like biological sponges. They attract and hold a lot of water, leading to massive swelling of the eye muscles and the retrobulbar fat pad.
And that swelling causes all the problems.
Yes. It increases pressure in the confined space of the orbit. That pushes the eye forward, proptosis, impairs fluid drainage, eyelid swelling, restricts muscle movement, diplopia, and in the worst case, compresses the optic nerve, DON.
The immune process targets those fibroblasts via the TSH receptors. Anything else involved? IGF-1R.
The TSH receptor on orbital fibroblasts is definitely the key player. There's been a lot of research into the insulin-like growth factor 1 receptor, IGF-1R, potentially playing a role too, maybe interacting or cross-talking with the TSHR signaling pathways. This led to the development of teprotumumab, which targets IGF-1R, but the exact mechanisms are still being fully worked out.
What increases the risk of getting GIGO or making it worse?
Smoking is number one, a huge risk factor, even stronger than its link to the hyperthyroidism itself. Thyroid dysfunction, either poorly controlled hyperthyroidism or hypothyroidism, is also a risk. Maintaining stable euthyroidism is protective. And as we discussed, RAI therapy without steroid prophylaxis is a major risk for worsening GIGO.
And cholesterol.
That's a newer finding. Hypercholesterolemia seems to be associated with increased risk, and some preliminary data suggests statins might even have a protective effect, though more research is needed there.
How do you assess Eugel-Boyle severity and activity?
We use clinical classifications. The NOSPEC score helps grade severity based on signs like proptosis and muscle involvement. The clinical activity score, or CAS, assesses inflammation looking for things like pain, redness, swelling. A high CAS indicates active inflammation, which guides treatment. TSH receptor antibody levels are often high. Orbital imaging, CT or MRI, is crucial if DON is suspected, or to assess muscle enlargement and apical crowding at the back of the orbit.
Treatment sounds like it needs a specialized approach.
Absolutely. Referral to a specialized thyroid eye clinic with a multidisciplinary team, endocrinologist, ophthalmologist, is ideal. Quality of life assessment using the GOQOL questionnaire is important, and smoking cessation cannot be stressed enough. It's critical.
What about general eye care?
Simple measures help a lot. Artificial tears for dryness, sunglasses for light sensitivity, sometimes sleeping with the head elevated to reduce morning eyelid swelling.
And thyroid management.
Aiming for stable euthyroidism quickly is key.
Yeah.
ATDs or a thyroidectomy are generally preferred over RAI in patients with active or significant JUGO, unless steroid cover is used with RAI.
Now, for the eye-specific treatments, what about mild GO?
For mild inactive JU, often just observation, and those supportive measures are enough. For mild active JU, a 6-month course of selenium supplementation, like sodium selenite 100 mg twice daily, has shown benefit in European studies, particularly in areas with mild selenium deficiency. It seemed to improve quality of life and slow progression.
And for active, moderate to severe GIGO?
The first-line treatment is intravenous methylprednisolone, IVMP pulses, high-dose steroids given IV in cycles.
Why IV instead of oral prednisone?
IV pulses seem to be more effective and generally have fewer systemic side effects than long-term high-dose oral steroids. There are standard protocols, like maybe 4.5 grams total given over 12 weeks, with higher cumulative doses, like 7.5 G, reserved for more severe or resistant cases.
But 5e steroids still have risks.
Oh yes, significant risks, especially with higher cumulative doses. Cardiovascular events, liver toxicity, monitoring liver enzymes is crucial, worsening blood sugar control, mood changes, infection risk. Careful patient selection and monitoring are essential. Sometimes other immunosuppressants like mycophenolate are added to enhance the effect or allow lower steroid doses.
And teprotumumab, the IGF-1R inhibitor.
Teprotumumab represents a major advance. It's a monoclonal antibody given by IV infusion. Clinical trials showed really impressive results, significant reductions in CAS scores, proptosis, double vision, and marked improvements in quality of life for patients with active, moderate to severe GIGO. The main ones currently are its very high cost and emerging safety signals like hyperglycemia, and notably reports of persistent sensorineural hearing loss in some patients, which requires careful monitoring. It's changing the landscape, but access and long-term safety are still being evaluated.
What if IVT or teprotumumab aren't options or don't work? Second line.
Other options include rituximab, targets B cells, mixed trial results for GO, tocilizumab, targets IL-6 receptor, some positive data, or orbital radiotherapy in some centers, though its efficacy is debated.
And for sight-threatening DIGO, do on.
That's an emergency. Immediate high-dose IVMP, often 1 gram daily for 3 days. If vision doesn't improve rapidly within a week or two, urgent surgical orbital decompression is needed to relieve pressure on the optic nerve.
And once the inflammation settles, inactive GIGO.
Once the disease has been stable and inactive for at least 6 months, rehabilitative surgery can be considered. This might include orbital decompression to reduce proptosis, eye muscle surgery to correct persistent double vision, and eyelid surgery to fix retraction or cosmetic issues. These are usually done in a specific sequence.
Let's briefly cover Graves' dermopathy, the skin issue.
Right, much rarer than GOGO. Usually occurs in patients who also have severe GOGO and very high TSH-RAB levels. It's characterized by thick, non-pitting edema, often with a purplish or violet discoloration and that peau d'orange, orange peel texture. Most commonly affects the shins, pretibial myxedema, but can occur elsewhere.
Same underlying mechanism.
Believed to be similar to GOGO TSH receptor activation on dermal fibroblasts, leading to GAG accumulation in the skin. Often it regresses spontaneously over time. It's bothersome, potent topical steroids under occlusion or compressive bandages can help.
Now, pregnancy. This is such a critical area. Managing thyroid issues while protecting both mother and baby.
Indeed. The maternal immune system undergoes massive changes during pregnancy, directly impacting autoimmune conditions like Graves. And managing thyroid function requires extreme care.
You mentioned HCG earlier, the pregnancy hormone. How does that play in?
Human chorionic gonadotropin, HCG, has some structural similarity to TSH. So in situations with very high HCG levels like severe morning sickness, hyperemesis gravidarum, multiple gestations, twins, triplets, or molar pregnancies, the HCG itself can weakly stimulate the TSH receptor, causing a transient physiological hyperthyroidism, usually in the first trimester.
But actual Graves' disease in pregnancy.
It's less common, but managing it is complex.
Yeah.
Pregnancy itself often suppresses the autoimmune activity, so TSH-RAB levels might fall. But there's a significant risk of a postpartum flare-up as the immune system rebounds after delivery.
And the risk to the fetus from the mother's antibodies.
This is crucial. Those stimulating TSH-RABs can cross the placenta. If levels are high enough, often cited as 3 times the upper limit of normal, they can stimulate the fetal thyroid, causing fetal or neonatal thyrotoxicosis. This risk exists even if the mother herself is hypothyroid because she had prior RAI or surgery. The antibodies can still be present.
That's a vital point. Diagnosis during pregnancy sounds tricky too.
Very tricky. Normal pregnancy changes thyroid-binding globulin TBG levels, which affects total hormone measurements. TSH levels normally dip in the first trimester due to HCG. So it's absolutely essential to use trimester-specific reference ranges for TSH and free T4, T3 when assessing thyroid function in pregnant women.
And treatment. ATDs seem like a necessary evil here.
Medical therapy with ATDs is the mainstay during pregnancy. The goal is not perfect maternal euthyroidism. The critical aim is mild maternal hyperthyroidism, keeping the mother's free T4 at or just slightly above the upper limit of the non-pregnant reference range.
Why undertreat the mother slightly?
To avoid fetal hypothyroidism. Overtreating the mother and making her hypothyroid can make the baby hypothyroid too, which can impair neurocognitive development. So we use the lowest possible ATD dose to control the mother's symptoms while prioritizing fetal safety. We do not aim to normalize the mother's TSH.
And the PTU versus methimazole debate in the first trimester.
This has been debated for years. MMI and carbimazole carries a small but definite risk of specific severe birth defects, methimazole embryopathy, particularly between weeks 6-10. PTU was historically preferred in the first trimester because its associated birth defects were considered less severe, although it carries that black box warning for potential maternal liver failure.
So what's the current thinking?
Recent analyses suggest both drugs carry small risks. Maybe MMI's risk is slightly higher for major defects. Some guidelines suggest PTU for the first trimester, then potentially switching to MMI for the second and third. Others argue that switching might not reduce risk, and sticking with one agent at the lowest dose is reasonable. It requires careful discussion with the patient about the relative risks. Lowest effective dose is key, regardless of agent.
How often do you monitor?
Maternal thyroid function, TSH and free T4, should be checked roughly every 4 weeks. If maternal TSH RABs are high, fetal monitoring with ultrasound looking for goitre, heart rate changes, growth issues, is also important from mid-pregnancy onwards.
And other treatments. RAI. Surgery.
RAI is absolutely contraindicated throughout pregnancy. Prolonged use of iodide is also avoided due to risk of fetal goitre. Surgery is rarely needed but might be considered in the second trimester if ATDs are poorly tolerated or require very high doses.
What about postpartum thyroid issues?
The postpartum period, roughly 4–12 months after delivery, is a high-risk time for new onset or recurrence of thyrotoxicosis due to that immune rebound. It's important to distinguish a transient postpartum thyroiditis, destructive, usually TPO-AB positive, low RAIU, from a true Graves relapse, TSH-RAB positive, normal high RAIU, as their management differs.
Preconception counseling sounds essential.
Vital. Discussing risks, optimizing thyroid function before conception, considering definitive therapy like thyroidectomy pre-pregnancy. For some women, it's all part of planning for the safest possible pregnancy.
And breastfeeding.
Small amounts of ATDs do pass into breast milk, but studies suggest that with standard doses of MMI, up to 20 millicard, or PTU, up to 300 millicard a day, adverse effects on the infant's thyroid function are rare. Monitoring the infant's thyroid function is sometimes recommended.
Okay, let's quickly run through some of the other causes of hyperthyroidism beyond Graves. Inherited non-immune.
Very rare. Autosomal dominant condition caused by activating mutations in the TSH receptor gene itself. The thyroid is on from birth, independent of TSH or antibodies.
Toxic multinodular goitre, TMNG.
Common, especially in older individuals in iodine-deficient regions. Multiple nodules in the thyroid gradually become autonomous, producing excess hormone. Hyperthyroidism is often milder than Graves, sometimes mainly presenting with cardiac symptoms like AFib or obstructive symptoms from the large goitre. RAI or surgery are definitive treatments. Sometimes long-term low-dose ATDs are used in the elderly or frail.
Toxiconoma.
Similar mechanism, but it's just a single autonomous nodule doing the overproducing. Usually needs to be fairly large, Erichi 3 centimeters, to cause overt hyperthyroidism. Again, milder symptoms than Graves, no orbitopathy. Treatment can be RAI, surgery, often just removing the half of the thyroid with the nodule hemithyroidectomy, or increasingly thermal ablation techniques like radiofrequency ablation, RFA.
Subclinical hyperthyroidism, we touched on this. Suppressed TSH, normal FT4, FT3.
Right, a biochemical diagnosis. The controversy is when to treat, but there's good evidence it increases the risk of AFib and bone loss, especially in postmenopausal women and those over 65. Treatment is generally recommended for these higher-risk groups, or if symptoms are present. Others might be monitored.
Iodide-induced thyrotoxicosis, dog-baster.
Triggered by exposure to a large iodine load, like IV contrast dye, some supplements, amiodarone, primarily in people who already have underlying thyroid autonomy, like TMNG or latent Graves. The excess iodine fuels the fire, often self-limiting once the iodine source is removed, but might need temporary treatment.
Amiodarone-induced thyrotoxicosis, AOT.
Complex. Amiodarone is loaded with iodine and is directly toxic to thyroid cells. It causes 2 types. Type 1 is iodine-induced hyperthyroidism in someone with underlying autonomy. Treat with ATDs, maybe perchlorate. Type 2 is a destructive thyroiditis caused by the drug's toxicity. Treat with glucocorticoids. Differentiating them, often using thyroid ultrasound Doppler flow, is key. AIT carries significant cardiovascular risks.
Very rare causes. TSH secreting pituitary tumors.
Extremely rare. A pituitary adenoma inappropriately producing TSH, leading to high TSH and high T4, T3, unlike primary hyperthyroidism, where TSH is suppressed. Needs careful distinction from thyroid hormone resistance, RTH. Requires pituitary imaging and specific treatments.
HCG-induced.
From tumors producing massive amounts of HCG, like hydatidiform mole or choriocarcinoma. The high HCG stimulates the TSHR. Treat the underlying tumor.
And transient thyrotoxicosis from thyroiditis, the leaky gland causes.
Right, characterized by abrupt onset, release of preformed hormone, often followed by a hypothyroid phase, and importantly, low radioactive iodine uptake. Subacute declare-vein thyroiditis. Often follows a viral illness characterized by neck pain, can radiate, fever, fatigue, high inflammatory markers, ESR, high T, very low RAU. Treat with NSAIDs or glucocorticoids for pain. Painless, silent lymphocytic thyroiditis, autoimmune, often TPO-AB positive. Similar hormone release pattern, but no neck pain. Can occur postpartum. Low RAIU usually just needs beta blockers for symptoms. Drug-induced thyroiditis can be caused by drugs like interferon, checkpoint inhibitors, amiodarone, type 2 AIT, lithium, low RAIU. Management depends on the drug and severity.
And other causes of thyrotoxicosis with low RAIU.
Thyrotoxicosis factitia. Taking external thyroid hormone, levothyroxine or T3, key clue is suppressed TG, along with suppressed TSH and low RAIU. Struma ovariae, rare ovarian teratoma containing functional thyroid tissue. Low RAIU in the neck, potentially high tachycardia, pelvic mass on imaging. Metastatic thyroid cancer. Very rarely, widespread functional follicular thyroid cancer metastases can produce enough hormone to cause thyrotoxicosis. Very high TG, low RAIU in neck, uptake seen elsewhere on whole body scan.
Wow, okay. We have covered a huge amount of ground, from the common to the rare. But now we need to confront the most critical, life-threatening end of the spectrum, thyroid storm.
Yes, this is the endocrine emergency. It's a severe acute worsening of thyrotoxicosis. Thankfully rare, but it carries a high mortality rate, maybe 10–25%, even with prompt, intensive treatment. It's complex, heterogeneous, and requires high clinical suspicion.
You emphasize clinical suspicion because hormone levels don't always track with severity.
Exactly. That's a critical point. You can't diagnose or grade thyroid storm based on T4 or T3 levels alone. They don't correlate well. The presentation is highly variable and can mimic sepsis, heat stroke, malignant hyperthermia, or other critical illnesses.
What are the classic signs, then?
Severe hypermetabolism, very high fever, often 103 degrees of Pfeffer or 39.4 degrees C. Extreme tachycardia, often out of proportion to fever. Heart failure, high output failure. Significant central nervous system effects ranging from severe agitation, delirium, psychosis, seizures, to lethargy and coma. Also, prominent gastrointestinal symptoms like nausea, vomiting, diarrhea, abdominal pain, even jaundice.
And the apathetic storm.
A dangerous variant, often in the elderly. Marked weakness, apathy, confusion, muscle wasting, cardiovascular collapse, but without the high fever or overt hyperactivity. Just as deadly, perhaps even more insidious.
Well, it usually pushes someone into storm.
Usually occurs in someone with underlying, often undiagnosed or poorly treated, Graves' disease. Precipitating factors are common: severe infection like pneumonia or sepsis, surgery, especially thyroid surgery in an unprepared patient, trauma, stroke, diabetic ketoacidosis, pulmonary embolism, stopping ATDs abruptly, high iodine load, contrast dye, even vigorous palpation of the thyroid gland in some cases, or childbirth.
Diagnosis relies heavily on clinical picture, then.
Primarily, high index of suspicion in a critically ill patient with signs of severe hypermetabolism and organ dysfunction, plus evidence of underlying hyperthyroidism, known history, goitre, eye signs, suppressed TSH high FT4, FT3, if available quickly. Scoring systems exist, but clinical judgment is paramount. Assessing major organ dysfunction, CNS, cardiovascular, hepatic, GI, is key. Differentiating from other critical illnesses is the challenge.
Treatment must be immediate and aggressive in the ICU.
Absolutely. Multi-pronged approach. First, aggressive supportive care. 4V fluids, electrolytes, cooling measures, cooling blankets, acetaminophen, not aspirin, as it can displace thyroid hormone from binding proteins. Oxygen, maybe mechanical ventilation, sedation if agitated, treatment of the underlying precipitating cause, e.g. antibiotics for infection, nutritional support.
And the specific antithyroid therapies, what's the critical sequence?
Okay, this is key. 1. Beta blockers. Start immediately. Propranolol is often preferred, non-selective, reduces T4 to T3 conversion, available IV. Esmolol, short-acting BAV, is another option, especially if heart failure is a concern. Goal is heart rate control. 2. Antithyroid drugs, thianabes, give a large loading dose, then regular maintenance doses. PTU is traditionally preferred in STORM because it inhibits T4 to T3 conversion, but MMI can also be used if PTU isn't available or contraindicated, for example, severe liver disease. Give orally, via NG tube, or rectally if needed. 3. Iodine solution. Crucially, give this at least 1 hour after the first ATD dose. Options are Lugol solution, or SSKI orally, or sodium iodide 4. Iodine rapidly blocks the release of stored hormone from the thyroid, Wolff-Chaikoff effect. Giving it before the ATD could theoretically provide more substrate and worsen things briefly. 4. Glucocorticoids. High-dose 4 steroids, for example, hydrocortisone or dexamethasone. These reduce peripheral T4 to T3 conversion, treat potential relative adrenal insufficiency, common in critical illness, and may have some effect on the autoimmune process if Graves is the cause.
So beta blocker, then ATD, then wait an hour, then iodine, plus steroids. That's the core.
That's the core specific therapy, alongside the vital supportive care.
What if that's not enough? Second-line options.
If the patient isn't improving, consider therapies to remove thyroid hormone and antibodies from circulation. plasmapheresis or plasma exchange, possibly dialysis. Lithium can sometimes be used to block hormone release if iodine can't be used. Clostridium can bind hormone in the gut to reduce reabsorption. Thyroidectomy is a last resort in refractory cases, but only feasible if the patient can be stabilized enough for surgery.
And follow up after the storm resolves.
Continued ATD therapy is essential. Careful monitoring is needed, recognizing that thyroid function tests might remain abnormal for a while due to non-thyroidal illness syndrome effects. The focus remains on clinical improvement and ongoing treatment of the underlying hyperthyroidism.
This has been an incredibly thorough journey, from the quiet biochemical whispers of subclinical hyperthyroidism all the way to the roar of a thyroid storm. It really underscores the thyroid's profound influence on the entire body.
It truly does. And if we connect it back, achieving that professional level mastery isn't just about memorizing facts and pathways. It's about understanding the interconnections, recognizing the subtle variations in how patients present, weighing the risks and benefits of different treatments in complex situations, and making those critical decisions. Hopefully, this deep dive has helped build that kind of nuanced understanding.
I certainly feel like it has. You, our listener, now possess a deep professional level insight into these conditions. But here's a final thought to leave you with. We live in a world with increasing exposure to environmental factors, new medications, maybe even changing stressors. What role might preventative strategies, perhaps personalized medicine approaches, play in the future to mitigate the rising tide of autoimmune conditions like Graves' disease? Thinking about everything we've discussed, what stands out to you as the biggest challenge, or maybe the biggest opportunity in thyroid health moving forward?